Yes, yes, sir.
Hari.
Good evening and welcome to another episode of Masterclass. This is the second program this year. The program will be initially beginning with a talk on meta-analysis based on an example, and then we will have the case presentation and the discussion by the experts. The case will be presented from Madras Medical College, and it will be discussed by team from PGH Chandigarh. So over to Dr. Venugopal and Dr. Arun for the details.
Thank you, Hari. I think we are in for a very exciting and educative evening. We have a topic presentation on medical statistics first, and then this will be followed by a case discussion, which will be the faculty for this are four eminent professors, Dr. Vyasadhar Rao, Dr. Jagan Mohan Taragan, Dr. Ajay Behel, and Dr. Justin Paul. The faculty is presenting case presentation will be Dr. Sudarshan from Madras Medical College. The student panelist Dr. Chinmay Ankaleshwar and Dr. Sudeep from PGH Chandigarh. Over to the first talk, may I invite Dr. Rizwan, who is the scientist ICMR at the National Institute of Epidemiology, Chennai. The first time I heard the term meta-analysis was when Dr. Salim Yusuf, way back, introduced this term along with his trials. So I'm just looking forward to Dr. Rizwan's talk. How it will be enrich. Over to Dr. Rizwan. Dr. Rizwan.
Thank you very much, sir, for that kind introduction. Before I begin my speech, I just wanted to introduce myself. My name is Rizwan. I work as a scientist in the ICMR National Institute of Epidemiology, which is located in Chennai. We are primarily an institute who do research on public health problems, and we are one of the premier institutes of the Indian School of Medical Research.
Can you speak a little louder, Dr. Rizwan? Little louder, please.
Yeah. I'm here to talk about interpreting forest plots, which are one of the outputs of meta-analysis. I'm going to share my screen. Since I have 15 minutes time, I will try to be brief, but if there are any pending questions, we can deal with it at a later time. So at the end of this lecture, you should be able to identify the parts of a forest plot and interpret the results presented in the forest plot. So that is my objective. Here I give you an example of comparing metformin with placebo for increasing the ovulation rates in PCOS. And these are the different studies. And in the second column, you see the odds ratio for ovulation rate. So each study found a different odds ratio for metformin for inducing ovulation rate in PCOS. For example, Fleming 2002 found an odds ratio of 2.51, which means patients who take metformin are 2.5 times more likely to get ovulation compared to those who took placebo. So that is what this means. Now there are 7 studies listed here, and they have reported widely different odds ratios. Now, meta-analysis tries to summarize this into one single estimate. How do we do it? Can we take a simple mean, a simple average? Can we add all of them and divide by the total number of studies? Does that make sense? As many of you will agree with me, it does not make sense, because if we do that, we will be giving equal weight to all of these studies, and it may not be correct. So what we do in practice, in meta-analysis, is we find something to give different weights to these different studies. And one of the common approaches is to weight them according to their sample size. So the larger the study, we give larger the weight. We say that they are more important. So this is how we calculate the weights. The formulas for calculating weights are slightly different for different types of meta-analysis, but just to give you a rough guide, they are based on the inverse of the standard error. Now what we do is we multiply this odds ratio with the weight, and we get something called weighted mean. Now this 3.88 is the pooled effect. That is what we called in that is what we call it in meta-analysis speech. So this 3.88 is the pooled effect of all the odds ratios which are seen. Now this is what meta-analysis is in a nutshell. And there are different ways of calculating weight, as I said. If you use this formula, we call it fixed effect meta-analysis. If you use this formula to calculate the weight, we call it random effects meta-analysis. There are different types of effect sizes that we can pool. The one which I just showed you now is called odds ratio, but you can also pool risk ratio, risk difference, mean difference, standardized mean difference. You can also pool ordinal data, count data like prevalence, incidence, time to event, hazard ratio, incidence rate ratio. So all these measures can be pooled in a meta-analysis. After you do the meta-analysis, it is now time for you to show it in the form of a plot. And the most commonly used plot is forest plot. It is a simple diagram like this. It has a y-axis and an x-axis. The y-axis contains or shows the effect size. So for example, in this case, it shows the odds ratio, 1.0, 2.0, 5. And on the left-hand side, it is decreasing. That is less than 1. This vertical line is drawn at the point of no effect. So for odds ratios, relative risk, hazard ratio, this line will be drawn at 1. For other measures like mean difference, it will be drawn at 0, because that is where the line of no difference. So this is the basic structure of a forest plot. This is an actual forest plot published from a study from the table that I showed you earlier. So I will show you or walk you through the different parts of the forest plot. Now these are the study IDs where we mention the name of each study. These are the number of participants which are included in the study. So here it means 37 out of 45 had ovulation. In the control arm, 30 out of 47 had ovulation in the control arm. So that is what it means. There are different ways of showing this. In the previous slide, I showed you numerator by denominator, but you can also show mean and standard deviation like this for a different study. So the number of people who are in the treatment group, the mean and standard deviation of that group, number of people in the control group, mean and standard deviation of the control group. So you can also represent like in this column, you can see the weights which are given for each of the studies, and the amount of the size of the box which are shown here is a representation of the weight. So the larger the weight, the larger the box. I will come to the boxes in a while. And the individual study results which are reported in the paper itself. So that is what is given in the right-hand side column. These columns may appear in different places depending upon how the authors choose it. But this is the example. This is the result of this particular study. So Fleming 2002 has reported an odds ratio of 2.51 with a 95% confidence interval of this one. Now I will talk to you about what the box and the line means. The box is the point estimate of the individual study, which means what is the odds ratio reported. And the horizontal line demonstrates the confidence interval. So this study has this point estimate, and its confidence interval extends from this point to this point, lower confidence interval and upper confidence interval. So that is what the box and the line mean. As I said before, the size of the box demonstrates how important the study is in this meta-analysis. On the left-hand side, you have favors treatment, and on the right-hand side, you have favors control. If this is a intervention which reduces the outcome, for example, vaccine. If this is an intervention which causes something or causes harm, then it will be on the other side of the graph. So this is the harmful side or this is the protection side, depending upon whether it is a preventive or harmful factor. So here I show you the point estimate of a single study, and this is the 95% confidence interval. And based on the width of the line, you can see which studies are precise. If the width of the line is small, it means the study is very precise. For example, this one. If the width of the line is very large or very long, then we say it is imprecise. Now, this is the result of the meta-analysis. You can see a small diamond here, the total number of participants across all the studies, the total weight, and the pooled effect. This is the meta-analyzed effect. Now, what does the diamond mean? The center of the diamond shows you the center of the pooled estimate, whereas the edges of the diamond indicate the 95% confidence interval of the pooled estimate. Now, in most of the forest plots, they have this test for overall effect, which gives you the p-value for the whole thing, whether this meta-analyzed result, this pooled result, whether it is statistically significant or not. One important thing that we have to keep in mind when interpreting forest plots is the heterogeneity. Heterogeneity is a measure of saying how similar or dissimilar studies are. One of the problems with meta-analysis is many people try to combine different types of studies which are very heterogeneous. In meta-analysis parlance, we call it apples and oranges cannot be combined. So to assess this, we calculate something called as heterogeneity. Highly heterogeneous studies means they are very different from each other. Low heterogeneity studies means we are clubbing studies which are similar to each other. And this basically depends upon the effect size and the variance of the individual studies. If the studies are too heterogeneous, meta-analysis is not justified. That is what we call apples and oranges cannot be combined. There are various ways of detecting heterogeneity, two main ways. There is a statistical test, which is similar to a chi-square test. Contrary to regular p-values, we want this p-value to be non-significant so that we can say the studies are not heterogeneous. And there is something called I-square, which we calculate. This I-square value determines how much heterogeneity is. If it is 25%, we say it's low, 50% for moderate, and 75% for large. Usually 50% or less is acceptable for meta-analysis. And this is the place where we report the heterogeneity. You can see the p-value for the heterogeneity given here, which is 0.42, which means that is the studies are not heterogeneous. It should be not significant, that is greater than 0.05. Now I have 2 slides left, and here I am going to show you an example which we did. It was published in Open Heart in 2024. The study looks at early AVR, that is aortic valve reconstruction, versus conservative therapy for aortic stenosis on all-cause mortality. ACM stands for all-cause mortality. There are 2 different types of studies which we included, randomized controlled trials and observational studies. And you can see there are 2 studies, Banovic 2021, CAN 2020 in the RCT. And there are 5 studies for observational group. And you can see how precise the studies are, how the point estimates are there. Generally, they are on this side of the forest plot, which means they are protective or they are reducing the all-cause mortality. That is, early AVR is beneficial for all-cause mortality. That is, it reduces all-cause mortality compared to conservative management. If you can see the diamond for the RCTs, although it is on the left-hand side of the graph, the upper part of the diamond is crossing the null line, which means the result is not significant. It reduces mortality by 0.5, that is 50%, but the confidence intervals are not, too wide to make any certain conclusion. On the other hand, the observation studies, you can see the diamond is completely on the left side of the null line, which means the result is very precise as well as very meaningful. It reduces the all-cause mortality, that is early AVR reduces all-cause mortality by 60%. And the confidence intervals are also relatively precise. If you pool all these studies, you get an even more precise estimate. And you can see the heterogeneity values here. I square is 31%, which means low heterogeneity. The I square here is 89%, which means high heterogeneity. And together there is 84% heterogeneity. And this is how we interpret the results of this particular study. I will end with one last example. This is a study which we published in the Indian Journal of Community Medicine. We looked at the risk of cerebral venous thrombosis and also other types of thromboembolic and hemorrhagic events after receiving Covishield. So this is whether giving Covishield results in cerebral venous thrombosis. And you can see all the studies are on the right-hand side, which means giving Covishield increases the risk of cerebral venous thrombosis. We divided the studies into two types. One is one dose only, risk after one dose and risk after two doses. And this was the risk period, number of days after giving the vaccine, the age group included in the study, what was the comparison arm, what was the design of the study, and the pooled estimate is 3.5, which means if you receive Covishield, the risk of having cerebral venous thrombosis is 3.5 times more in the 0 to 28 day period compared to either not receiving the vaccine or compared to before receiving the vaccine. And the two dose study, there was only one study which did not give any significant results. So this is another example which is related to maybe cardiac. So the take-home messages are three main things. Meta-analysis is nothing but a weighted average of the different studies which we would like to pool. Forest plot is a graphical representation of this so-called meta-analysis. Heterogeneity explains how much dissimilarity is between the studies, and we should be mindful of this heterogeneity when we are interpreting results of meta-analysis or forest plot, so that we don't place too much emphasis on combining apples and oranges together. That is all I have for you. Thank you very much.
Thank you, Dr. Rizwan, for a wonderful presentation. Any questions? So when you select studies for this meta-analysis, how will you select studies? Can you, how will you make sure that all the studies are included? Any guideline for that, or you have to register in Prospero, all those things are there, or how is it?
Yeah. So we begin with writing a protocol like for any other study. And this protocol has different items which you have to follow, and you have to register it in Prospero or any other registration services. And like you would do for a primary study, you would devise inclusion-exclusion criteria for the studies that you will include. And you have to make sure that while defining these inclusion-exclusion criteria, that the studies that you will include in your meta-analysis are homogeneous. So that is how you will select the studies. And you will do the search in multiple databases, not just one database like PubMed. You will do it in PubMed, Embase, Scopus, Google Scholar, Web of Science, so that you throw a wide net so that you don't miss any studies that are relevant.
When you select, this may sound a very foolish question. When you select the studies, how do you exclude the selection bias in the study? Very often we may select studies of the similar nature, and then we may get a biased opinion. So how do you prevent that?
Yeah, this is a very valid question, and this is one of the limitations of meta-analysis. You can never be sure that you have included all the studies which have been done on this topic and the studies which are relevant to you. But there is a way to assess this, and we call it publication bias. Publication bias refers to the phenomenon that studies which do not have a very surprising effect or very interesting result, they do not get published. And in meta-analysis, we only look at published literature. So when you only take published literature, they are more likely to have interesting findings than unpublished literature, which do not have interesting findings. This is also called the drawer effect, where unpublished studies are kept in drawers and do not see the day of light. There are ways to overcome this as well, where we look for, and these studies which are kept in the drawer can be retrieved in some fashion or way. And these are called gray literature. There are websites and there are services which document these gray literatures. One such example is postgraduate thesis. There are many studies which are done by postgraduates which do not go out of the thesis. So there is a website called Shodh Ganga, which lists all the titles of the postgraduate thesis. So this is just one example of how we can achieve balance in those terms to avoid that bias that you're referring to.
Dr. Raswan, one more question. So individual patient data you are not getting in many of the studies. You will get only the aggregated data. So will if you get the individual
Yes.
patient data, will it be a better type of this IPD meta-analysis is a better way of getting analysis, or what is your comment on that?
IPD meta-analysis is the, I would say, the ultimate goal, right? If I had the individual studies data, I can manipulate them, I can combine them in whatever way I like, and I have a lot of flexibility in combining the study results. But more often than not, people are not willing to share the data, or they might be very old and the data might be lost. Nowadays, especially for trials, they are required to make sure that the data is accessible. Nowadays we gave this data sharing statement or data availability statement in all the articles that we publish. So that is a step towards making data available. If you can do a meta-analysis of individual patient data, it will be much more robust than using aggregate data alone, but it is not always practically possible.
There's a question
There are
from
some questions in the
Arun.
chat box.
Does weightage take into account the design of the study, RCT versus observational studies? Dr. Arun has asked this question.
Yeah, no, we don't take into account the design of the study. The calculation of the weight primarily depends upon the variance or the standard error of the study. There are two different ways of calculating it. If you are only interested in variance within the study, then we say it is called a fixed effects meta-analysis. If we are worried about variance between the studies, then we use something called the random effects meta-analysis. No, we do not take into account the design, but a meta-analysis of RCTs has more credibility compared to a meta-analysis of observational studies.
Okay. So any other comments or questions? Shall we move to the case presentation? Thank you, Dr. Raswan, for the wonderful presentation and the nice discussion. I think we will trouble you again in the future for more presentations in this forum.
Thank you.
It's a pleasure, sir. Thank you very much.
Thank you.
Okay. Can we go to the next part of the program, that is the case presentation? The case is being presented by one second.
Sudarshan.
Dr. Sudarshan?
Yes, sir.
And you are ready with your
Yes, sir. Yes, sir. I'm ready with me.
have you shared your slides?
Yes, sir. I will share.
I have great pleasure in inviting the distinguished panel of examiners, Dr. Dayasagar Rao, the Chief Cardiologist, KIMS Hyderabad, Dr. Jaganmohan Tharagan, former President Head of the Department of Cardiology at Sri Chitra, Dr. Justin Paul, Professor of Cardiology at Madras Medical College, and Dr. Ajay Bahal, Professor of Cardiology at PG at Chandigarh. So over to the examiners and the presenter. And the student panelists, Dr. Sudeep and Dr. Chinmay. Yeah, you are ready
Yes, sir.
to answer all the questions? Okay, then let's start with the case presentation.
Yes, sir. Good evening, sir. I'm Dr. Sudarshan, currently doing second year postgraduate in Madras Medical College. This is a case of interesting case of heart
No,
failure.
you can share your slide, please.
Yeah, I shared, sir.
Yeah, please.
Not yet. Is
Not
it
yet
visible, sir?
shared. Not
Okay.
yet.
One second.
Can use that share button below. Yeah, it's coming. Okay, yeah, start.
Yes, sir. So, a case of Mr. X, 67 years female, hailing from Pondicherry, studied till 8th standard. She is a housewife, sir. Socioeconomic status of lower middle 3 by modified some case. Then she has a chief complaint of breathlessness for 2 years. So, history of presenting illness. Patient was apparently normal before 14 years. Then she had a breathlessness on exertion, for which she was evaluated outside and was found to have some heart disease. So for which she was treated with some drugs. Her symptoms improved after taking medication, but eventually she stopped taking medication for past 3 to 4 years. And at present, patient again started to develop complaints of breathlessness for past 2 years, which is insidious in onset, progressive in nature. Patient initially noted breathlessness while walking more than one flight of stairs, for which she used to take rest, and subsequently her symptoms reduced after taking rest. Then her breathlessness gradually progressed to she used to have breathlessness even for climbing less than one flight of steps. Then she used to start to have breathlessness on doing her day-to-day activities like walking within her house and taking bath for past 6 months. Here's a history of breathlessness. That too after 2 to 3 hours after sleep, on and off for past 6 months, which wakes her from sleep. And she also had complaints of breathlessness, which occurs immediately after lying down in supine position, which is associated with cough, which got relieved as she sits erect for past 1 week. Sir. Her breathlessness severity increased even at rest for past 3 days, for which the patient was hospitalized at present. So no history of chest pain, no history of palpitation, no history of fatigability, no history of leg swelling, no other specific complaints, sir. No history of syncope, no cough with expectoration, no hemoptysis, no fever, prolonged fever, no hoarseness of voice, no decreased urine output, no history of numbness and paresthesia of limbs, no history of recurrent LRTA, bluish discoloration of skin, no history of spotting episodes in the childhood. Then past history, known as of heart disease, just diagnosed since 2011, but she was on irregular treatment for past 3 to 4 years. History of hospitalization 6 months back because of increased breathlessness. Then after taking treatment, her symptoms reduced, but again she stopped taking drugs. Then the treatment history, tablet, which the patient told tablet penicillin and showed penicillin. The personal history, mixed diet, bowel and bladder is normal, no known addictions, married since 45 years, P2L2, last childbirth was 41 years before, menstrual history maintained menopause before 15 years, family history born of non-consanguineous marriage, no history of any cardiac disease or sudden cardiac death in family. So summary slide, 67 years female, known case of heart disease since 2011 for past 14 years. She was on irregular treatment for past 3 to 4 years, which is presented with progressive dyspnea and NIGA 2 for past 2 years, which progressed to NIGA 3 for past 6 months, which worsened from NIGA 3 to 4 for past 1 week, associated with PND and orthopnea, with the marked limitation of daily activities. So my differential diagnosis.
No. Come back. Stop at the summary.
Can ask the PGI team whether they want some more information on this, because they also have to find out from the history whether it's into some form of heart disease, some group of heart disease. PGI people, do they want to ask anything more?
Chinmay, speak anything?
You're muted. Please unmute yourself.
Hello.
Yes, Dr. Chinmay or Dr.
Yeah.
Any more questions you want to ask, or then you should discuss the history and possible diagnosis.
We'd like to ask if the patient had any history of fever, joint pains, or any history suggested of acute rheumatic fever in childhood.
No, sir. No.
Or
Sir.
earlier.
So there's no history of rheumatic fever.
No,
okay?
Sir. No, sir.
Anything else you want to ask? Pregnancy was uneventful, or was it
uneventful, sir? Uneventful, sir.
Uneventful pregnancies.
Yes.
Not toxemia, eclampsia, nothing.
No,
like
sir.
that.
No, sir.
Because today people are saying, if you had a preeclampsia and all, it's a cardiovascular risk over long term. Anyway, so that also isn't there. Then, would like to know why this patient had stopped medication but still was asymptomatic for 2-3 years, isn't it?
Yes, sir.
She was symptomatic 11 years ago. On treatment, she was improving, and then she stopped medications.
Yes, sir. She lost follow-up and she stopped medication.
You think it's two different diseases, or it's the same disease which has relapsed, or she was given some disease modifying medications which had been stopped, so the disease has recurred?
No, sir. The disease has been, the severity has been worsened. Previously, she was diagnosed to have
No, but
disease.
why she should have remained asymptomatic for 2 years off medications? That means there is some regression of her heart disease, and that's only possible with disease-modifying medications, isn't it? What is disease-modifying medication compared to symptomatic relief medications? Can you just go to one or two? These are symptom-related. These are disease-modifying.
Yes, sir. Like in TAFA amyloidosis, you can give some.
No, we're not talking about amyloid here. Just talking about disease-modifying medications of heart failure.
No, like
Compared to symptomatic,
all the drugs that, sir,
yes, sir.
all the drugs
Like,
that prevent remodeling of the
pillars
heart are disease
pillars of
modifying.
heart failure, yes, sir.
what are the symptomatic modifying interventions in a patient with heart failure? Drugs, non-drugs.
Diuretics are
Diuretics are
treatment symptom elevating drugs, whereas beta
doesn't
blockers
modify
are
the course of the disease. Same way digitalis. So what are the disease modifying interventions? When I'm telling you intervention, there are medications as well as non-medical, non-drug pharmacological.
Yes. Medications would be ACE inhibitors. ACE inhibitors will prevent the remodeling. So, sir, they are disease-modifying drugs.
RAS and isn't modifying medications. Which are the ones usually given? Which seem to be modifying the drug, disease, fibrosis, remodeling. Just tell us 1, 2, 3, 4. Yeah, you got
beta block.
Okay, beta blockers.
The beta blockers, ACE inhibitors. Even, sir, SGLT2 inhibitors.
MRA, sir, MRAs, it will prevent fibrosis, reduce fibrosis also. It decreases.
Intracortical receptor antibodies, huh?
Yes, sir.
Okay, then
just to
these
put
are standard questions.
Just to put it more simply, what are the drugs which modify the mortality?
Beta blockers.
Yes.
AC inhibitors.
Okay, the RAS modifying medications. Yes.
Mineralocorticoid receptor antagonists.
Once.
MRAs.
Yes.
Then SGLT2, sir.
SGLT2, does it modify the mortality?
Yes, sir. DAPA.
So SGLT.
Heart failure.
Yes,
sir.
They we are not sure they really do modify the disease process. They improve the immediate prognosis, certainly heart failure admissions, and multiple trials together shown improvement in mortality. But disease modifying reason is not very clear. But you may actually add it if you want. I'm not sure.
Yeah.
Okay, so obviously she must have not been on any of these disease modifying medications. She must have been only on symptom relief medications, isn't it?
Yes, sir. Yes, sir.
So that's why the question is, if all was stopped, why was she remaining asymptomatic for 2 years before she got a recurrence of symptoms? Very unusual, isn't it?
Yes, sir.
Usually,
she had yes, sir. She had her symptoms was not worsened during those times. She had a mild difficulty in breathing, with that too while doing more.
Okay, so she remained symptomatic even on those periods where she was off medications, isn't it?
Yes. Yes.
Okay, then the questions don't arise. Okay.
Is it possible? Is it possible that patient had some precipitating event about 10 years back?
Yes, sir. Yes, sir. Possible.
The precipitating event is
yes, sir.
What are the precipitating events you look for by history?
Yes, sir. We have to look for palpitations, sir. And we have to look for fever.
Best thing is you tell us
any respiratory tract infection or any arrhythmias are the two most important.
So one you want to call off arrhythmias, tachyarrhythmias, or even bradyarrhythmias.
Yes, sir.
In groups, no? Second one, endocarditis, infective endocarditis, isn't it?
Yes, sir.
Cardiac infection. So you call it as infective endocarditis. Anything else?
Attacks of febrile fever. Sir, any respiratory tract infection?
Okay, which could acutely worsen the symptoms. And yeah. Okay.
Any idea why an infection precipitates the heart failure mechanism?
So maybe due to a cytokine storm which leads to vascular collapse.
Cytokine storm is a very big word.
You're gone to cytokine storms too early.
Yeah. More commoner than that. What are the immediate precipitating events? Forget about the disease. What are the things, what hemodynamic changes that
increased heart rate, sir.
Heart failure.
Increased heart rate.
Increased heart rate.
Increasing the heart rate.
Yes,
Because
sir.
with
Decreased
fever
diastolic
and
filling time so that
infection, heart rate
process will be
yes. Then anyway, this patient has anyway compromised pulmonary function, isn't it?
Yes.
This infection, whatever it is going to worsen it and make the patient symptomatic, isn't it? Certainly, lower respiratory tract infection will certainly create worsening of symptoms. Maybe symptoms of heart failure, or it may be symptoms of breathing difficulty. Okay. So with this, can you tell us any etiological possibilities, or you think it is just heart failure? It's myocardial disease, or you think it's valvular heart disease, or you think it is some
related to cardiac
disease?
It's related, the symptoms are related to cardiovascular system. So the probable causes are, it may be due to valvular heart disease, or it may be due to a myocardial abnormality like heart failure with preserved ejection fraction. Because
earlier
disease.
Earlier to that, can we know whether it is a right-sided problem
no, sir.
or left-sided?
No, sir. It's a left-sided problem. Sir. It's a left-sided problem.
You can be a bit more precise on that.
Yes, sir. It's a left-sided problem.
Yeah, because of PND, orthopnea.
Yes, sir. PND and orthopnea. There are no signs of abdominal distension, no edema.
Okay, that's correct. So you're thinking of causes for left heart failure, isn't it?
Left heart failure, yes, sir.
Okay.
So left heart failure in a person who is about 50 years female.
Yes.
Possibilities.
Yes, valvular heart disease.
Valvular heart disease coming for the first time at the age of 50. What are the possible valvular heart disease?
LV inflow obstruction, sir.
They are being too weak.
67. So obviously we are not thinking of anything congenital, isn't it? You're probably looking at only acquired heart disease.
Yes, acquired heart disease. Yes.
Okay. So
go ahead. Anything else?
PGI team, you can also answer.
Sir, actually, we could not hear the question. Can you repeat the question, sir?
No. At the age of 50 years in a female having a left heart disease, what is the most likely cause of the disease?
50 years female, sir?
Yeah, this patient is a female, according to the history. They've been given a 51 years old.
67 years lady.
No, 67 years now, but she had the disease almost 14 years back.
Yes, you're right, sir. You're right.
So basically, at the age of 50s, she has developed a disease affecting what we assume to be a left-sided heart disease. So what are the possible causes of a left heart failure in a female who does not have, who has this PND and orthopneas? Commonly, what you see in the wards.
First and foremost, we should look for an ischemic disease, sir.
Any history of angina or anginal equivalent in the history?
No, sir. No history of angina.
So it is dominated by dyspnea.
Yes, sir. It's a predominantly symptom is predominantly this.
Yeah, at the age of 51 without any coronary risk factors. You can be generally having atherosclerotic heart disease as a first. It can be coronary dissection and some odd things which are common to females, but more common.
So since
she is postmenopausal, so then the risk stays the same for men or women.
So you have said that it is possible coronary artery disease. Can you list out some of the female specific risk factors for coronary artery disease which you should ask in history? Female gender specific risk factors for coronary atherosclerosis which you should ask for in history.
Sir, early menopause.
Very good. One is early menopause.
History of PCOS syndrome also.
Very good. History of PCOS.
Yeah.
OCPs. Use of OCPs. Sir, OCPs, even hypothyroidism.
It's not female gender specific, right?
Okay, good.
So can you, what about late menarche, infertility? These are all gender specific coronary atherosclerosis risk modifiers, and history of hypertensive disorders of pregnancy, history of gestational diabetes mellitus, history of other adverse pregnancy outcomes. We have a list of gender specific coronary atherosclerotic risk factors which you need to ask in every patient, with women in particular, where you suspect coronary atherosclerosis.
A poor obstetric history, people have now added on as one of the cardiovascular risk factors over time, including, as I said, hypertension in pregnancy, diabetes in pregnancy, even premature deliveries. So many things are.
Yes, a preterm delivery, small for gestational age. All these, basically the placental disease has a commonness with coronary atherosclerosis.
Okay. Anything else? Okay, you think it is valvular. Can it be myocardial? Pericardial, we expect that you would have got right heart symptoms more than the left heart. And usually, pericardial disease primarily don't come with left heart symptoms. They usually come with a complex symptomology, but predominantly right heart. What about myocardial diseases? What are the myocardial diseases which can present at 67?
Infiltrative cardiomyopathy, sir.
What is it?
Restrictive cardiomyopathies.
Restrictive. Yeah, all right.
No, does restrictive cardiomyopathy is a progressive disease or does it have an intermittent remissions? Here is a patient who had symptomatic and then had a relief for about 2 to 3 years, and then again reappearance of the symptoms.
Yes, sir. Symptoms got reduced, then it got worsened. Yes.
Yeah, he has sort of taken back that comment that she was asymptomatic during the drug-free period. She was symptomatic, but she didn't take
symptoms got less reduced.
Okay. So it had not regressed completely.
Yeah, sir, can I make a point, sir, here?
Go ahead.
Sir, it could also be that after the first episode of symptoms, the patient has reduced her activity, and then and that's why she had a relief of symptoms. But then the symptoms gradually increased. So anyway, it was an increase in the disease, but it was perceived as reduced symptoms.
Okay, it's possible. Very much possible. Yeah.
Okay, go ahead. So what are the other possibilities?
What about other myocardial diseases? Can it be a hypertrophic cardiomyopathy, end-stage hypertrophic cardiomyopathy?
Yes,
Could be an end-stage dilated cardiomyopathy.
Yes, sir. DCM, dilated cardiomyopathy.
Or, of course, as you correctly said, it could be some of those restrictive cardiomyopathies at 67 years. What are the restrictive cardiomyopathies that come to your mind?
Amyloidosis.
Ones or the other ones?
Amyloidosis.
Amyloids and sarcoids will come. Okay. So I think with these broad things, let's go forward. Let's go ahead.
Yes, sir. So my differential diagnosis is acute valvular heart disease, LV inflow obstruction, then heart failure with reserved ejection fractions. So I'm going to
you have become no. So please, I think we have some objection to your acquired heart disease with inflow obstruction, which has especially it has only to be mitral stenosis, rheumatic mitral stenosis, isn't it? Nothing else. Is there any other possibility in this acquired valvular heart disease with LV inflow obstruction?
Yes, there is no symptoms of palpitation.
No. Can the patient have?
No.
When you say acquired valvular heart disease with LV inflow obstruction, other than mitral stenosis, are there anything that come to your mind? unless you are talking about heavy calcific mitral annulus with usually mild mitral stenosis. Your diagnosis is mitral stenosis, is it?
Yes, somehow I think, sir, I find many times students say this, it's a LV inflow obstruction rather than mitral stenosis. I also don't really understand this is the way they should say that, or they
No,
could straight away
there's no
say mitral
problem.
stenosis.
There is no problem. We already discussed that congenital heart diseases, once you say LV inflow, you go from the mitral valve, subvalvular, mitral valve, parachute mitral valve, supramitral ring, quadriatrium, and then of course pulmonary venous obstruction. That is how you go backwards. But we decided that those are not likely. Pulmonary vein stenosis are there when you do AF ablation and all, but otherwise, generally it is
valvular heart disease.
Even mitral stenosis, other than rheumatic, the other etiologies are there to enumerate about 10 of them. But you hardly see any of them in your total career of 25, 30 years, right? Yeah, mucopolysaccharide disease, Fabry's disease, so many are there. I think just somebody can enlist it, the smarter guys, but you don't see any of them.
Except probably some or two cases of degenerative mitral stenosis we sometimes come across. One or two cases.
I have not seen yet a degenerative mitral stenosis other than mitral annular calcium. And that too, it's
annular calcium, sir. Increasing the gradients across the mitral inflow.
Yes, yes. The other one is, of course, if you intervene with putting some mitral clips, all mitral clips will cause relative mitral stenosis. Valve area comes down to around 2.5. And if you put 2, it will come down to as low as 1.5 to 1.8 mitral clips. So functional mitral stenosis is part of mitral clip. Yeah, that's
I think
that's also a good point. Heart failure with preserved ejection fraction is a good point. Yes.
But in the discussion of valvular heart disease, please do not forget drug-induced valvular heart diseases.
Methi surgery.
No, drug-induced. Methsurgery is no more used.
Oh yeah, drug-induced. Yes.
Yes. Drug-induced valvular heart disease has been described.
Yes.
Yeah.
Okay, that
which are the drug-induced valvular heart disease? You can just enumerate 2 or 3.
So one is mitral stenosis because of Methi surgery, sir.
Yeah. Surgery.
Anything else? Anything else? You forget about anorexogenic drugs like fenformin, fentanyl. It is no more available. But I think one of the drugs that should be considered, not in this necessarily this patient, cabergoline used for Parkinsonism.
Okay.
I think neurologists probably have said that they have stopped using cabergoline, but I'm not sure whether everybody is following that.
Yeah.
Okay. Yeah. Okay. Go ahead.
Okay, I think we'll go further because the history doesn't really give you a strong clue. It is just heart failure, that is left heart failure, that's all.
Yes.
Yeah.
The physical examination, patient was conscious, oriented, thin bill, nourished, no palatal sinus, clubbing, vital edema, no skeletal abnormalities, no extra markers, congenital heart disease, dramatic fever, height is 158 centimeter, arm span, weight is 48 kg, BMI is 19.2, arm span is 162, upper segment, lower segment is 0.86. Pulse is 60 per minute, sir. Right. Irregular, varying in volume. Peripheral pulse, all peripheral pulses felt. Symmetrical, no radiofemoral delay. Condition of vessel wall was normal. Apex pulse deficit is more than 10, sir. Blood pressure was normal, sir. Should be in all 4 limbs. Respiratory rate is 18 regular. Saturation is 92, sir. In room. Temperature is normal. JVP not elevated. In system.
Sorry, just go to the previous slide. I think you've gone too fast. Don't go too fast on positive, I think. Yeah. Okay, SpO2 is 98, 92. That is low,
Yes.
isn't it? Okay.
Yes.
Otherwise, there's nothing. All right, go ahead.
Yes, sir. Pulse is irregular.
Go ahead.
Serious examination, inspection, trachea, inspection and palpation, trachea and midline, chest wall bilaterally symmetrical, epixel pulse felt left trigger space, half-inch medial to mid-clavicular line, tapping in nature, P2 not palpable, diastolic thrill felt at epexer, no parasternal heave, no suprasternal, supraclavicular, so epigastric pulsation, no sinus scar, and dilated veins. Then percussion, right heart border is a substernal, left heart border corresponds to apex, left second intercostal space is resonant, liver dullness noted in right fifth intercostal space, midclavicular line, trough space is resonant, sir, on percussion.
Okay, please hold. Please go back to the previous slide. I think Chinmay or his colleague, we can just discuss now what are the possibilities. I think it is almost zero down to the diagnosis. Yes, please discuss.
Unmute, please.
What are the striking features in the physical findings?
What are the hemodynamic information you can gather as of now from the history, general examination, pulse BP, JVP, and the precordial examination?
Sorry, I missed the JVP. JVP, what was told?
JVP is not elevated normally.
Oh, it was
not elevated, but he didn't mention about the waveforms.
That's what I told you. You were going too fast. Yeah, now tell us this.
About the descents, whether descents were slow or descents were normal. Particularly, he has a mitral stenosis. He should have mentioned about whether wide descent was normal or wide descent was slow.
It's probably mitral stenosis, but without the PAH component.
Should the VY descent be slow? What are the conditions where you might get a slow VY descent?
Tricuspid stenosis.
Okay.
Associated tricuspid stenosis.
Right.
And can you have slow wide descent without tricuspid stenosis? Yes, no, or don't know.
Sure.
Why is the wide?
What is VY descent? He is asking you a very simple question. What is VY descent? What does it tell you hemodynamically? The rate of early diastolic filling of the right ventricle, right?
Yes.
So what all can obstruct the rapid filling of the right ventricle in early diastole? One, of course, you said tricuspid stenosis. Anything else?
Yes, sir.
With the RV severely hypertrophied and diastolic dysfunction.
Already RVDP is elevated. Yes.
Yes. RVDP with the diastolic dysfunction.
Dysfunction, yes.
Relaxation failure. Not the late failure. Late failure, the VY will be sharp. It will be the relaxation failure. No, hypertrophic cardiomyopathy, that type of things, right? Okay. Yeah, no, the apex in the fifth space just medial to the midclavicular line. That is the most important positive finding I would think in a patient who has heart failure, left heart failure. Can you please discuss? If I am telling that it's a very important clue. Whether it's tapping or not, it's very difficult to tell. Female patient, she may be obese, and the breast might actually come in your way of assessing the apex.
No, it is important because a lady who has gone through the disease process for 11 years, and yet there is no cardiomegaly.
Yes, sir. Couple of things are not matching here. He said a saturation of 92, and the respiratory rate and the heart rate were reasonably well controlled. So it was atrial fibrillation. And now he says there is no cardiomegaly, and it's predominantly LV type of apex, but there is no left parasternal heave with a class 3 symptoms.
Right heart is not involved.
Palpable. So there is no clinical features of right ventricular enlarged systolic overload. However, there are features of severe pulmonary venous hypertension as per the history.
Yeah. What are the causes of left heart failure with an apex beat which is just lying in the within the fifth interval? That means there is actually no left ventricular enlargement, isn't it? I'm asking you that question. What are the possibilities?
Heart failure with preserved ejection
fraction. Mitral stenosis, you already told. All LV inflow obstruction, mitral stenosis being.
Heart failure with preserved ejection fraction.
Hmm?
Heart failure with preserved ejection fraction.
Okay, you got the point, but all right. Yes. Diastolic heart failure, correct. So it can be restrictive cardiomyopathy or we are not considering pericardial disease because left heart symptoms are far more dominant and there are no right heart. So pericardial disease is out. Okay, good. So that itself gives you a point that mitral stenosis can be very high on the part, and diastolic thrill, the apex. Okay. It looks like a straightforward mitral stenosis, is it? So let us come to the auscultation. Yes.
Sir, S1 loud, but it's variable, sir. S2 heard, split is normal, sir. A2OS is soft, sir. No S3, S4. Murmur is low pitched, rough lumbering murmur. Grade 4 mid-diastolic murmur heard at apex with the bell of a stethoscope in left lateral position, predominantly at long cycle length, sir, with breath held in expiration. Pre-systolic accentuation best heard during short cycle.
Can I just stop you one? You've been very detailed, so I have to stop you. Predominantly at long cycle lengths. How does mitral stenosis behave with long cycle lengths? Can anybody else talk about? Yeah.
PJ team, please answer.
Mitral stenosis and long cycle lengths. It gives you a very important clue on the severity of mitral stenosis.
During long cycle,
isn't it? Huh?
During long cycle length, the duration of murmur will be increased in severe.
Long cycle lengths, what is increased?
Murmur durations.
Is it?
No, I just want to make one comment here. Pre-systolic accentuation is heard.
Yes, sir. Yes, sir. During short cycle length, it looks.
No. What is the pre-systolic accentuation due to?
It is because of atrial contraction, sir.
And then what is the rhythm here?
Yes, sir. But during short cycle length.
No. Wait a minute. Pre-systolic murmur being present is different from accentuation during pre-systole. Don't mistake.
Accentuation is a positive, isn't it? Positive event. Here the atria are dead. Yeah, I was coming to that later, but yes. So you can say there is a pre-systolic murmur.
Yeah.
Right? Accentuation is better you avoid in a patient with atrial. Better avoid. You may have some vague reasons for that, but and as you correctly said, the shorter diastoles, you will get a murmur which is going up to the first heart sound. Right? If the diastolic murmur goes up to the first heart sound in long diastoles, that indicates patient has severe mitral stenosis.
Yes.
That is the importance of short and long cycles in atrial fibrillation. Right?
My question to you again is, S1 is loud and variable. Then does it really vary with cycle length in mitral stenosis? Does the intensity of the first sound vary with the cycle length? I'm not talking about very long cycle. I'm talking the usual cycles of variation in atrial fibrillation with a ventricular rate of about 90 or so, what you have described there.
Yes, sir. Plus variable, sir. So, I'm not sure. It is not
variable in what way? You mean longer cycles will have a softer first heart sound?
Short cycle had a
yes.
Short cycle, the S1 was little bit louder, sir, compared to that's what.
The short cycle is terminated by a loud first heart sound or soft first heart sound?
So it was variable, sir.
It is variable, correct. But I want to ask you whether the first heart sound terminated by a long diastole is soft or loud as compared to a short diastolic.
First heart sound terminated by long diastole will be loud, so loud diastole.
No, you said pre-systolic murmur is present. So
yes.
Systolic murmur is present even in long cycles, right?
No, that's not there. It's only in
short
cycles.
Short cycles.
There is no gradient.
No, but he said the murmur is long and even in long cycles.
No. That isn't said, I think.
No, I think it's written down there. Rumbling grade 4 diastole.
Pre-systolic acceleration best heard during short cycle. Anyway.
Actually, he is trying to make two different points here. One, he wants to say that it's a significant mitral stenosis, that mitral murmur is too long and he's able to hear in the long cycles. And the second point he is trying to make is, in the short cycles, he is able to get an accentuation. In the long cycles, he is able to get a very long murmur. In the short cycles, he is able to get a pre-systolic accentuation.
Anyway, that I think we already discussed that generally we associate pre-systolic accentuation to a functional atrial contraction. But there may be other, as I said, there's always, there are explanations for various things. Many times it is the first heart sound gives you the feeling that the diastolic murmur is accentuating. That is also there. It's an auditory effect. But it doesn't matter. I think we should not discuss it anymore. We'll only just, I just thought, when there is, in a long diastole, if there is no gradient between the left atrium and the mitral, the mitral valve is already in a semi-closed position or almost in a closed position. So only tensing is there. So it may not be very loud as compared to an excursion followed by tensing. The start sound is actually by not the closure, it's actually the tensing or ballooning, like a sail. Yes. But that we are not going to go into details of that because it's a little confusing. So we'll just leave that. But that's what I thought. But it's possible that in mitral stenosis things may be different.
But I'm also amused by the fact that he said it is better heard with the bell. Nowadays, do the stethoscopes have a bell? There are textbook things, writing off. It's more like a reflex rather than an actual thing.
So they say that single-sided stethoscope, if you press firmly, it acts like a bell, and press lightly, it acts like a diaphragm. So,
no.
But I have not practically used that way. I have not found it any particular different that way.
Okay. I have a Hewlett-Packard stethoscope, which has a bell and a diaphragm.
No, some of the old timers certainly have it. It's more of archaic rather than what you call academic.
Yeah.
Anyway, that is beside the point. I'm only trying to say that, it is something like when you see a patient with MS, you start to tell all the criteria of an MS, what you have read in the book. It's not applicable to the patient's real thing there. Anyway, be that as it may. What are the other valvular heart disease is there? Only one valve disease is there.
Yes, sir. I'm able to hear only this package, sir.
Okay. Any other murmurs or anything else you look for to bring out any murmurs?
No, sir.
Nothing. So no maneuvers were done. You are quite happy with the diastolic murmur.
Isometric exercise and.
Why do you want to? You already have an atrial fibrillation, so I don't think you can really do an isometric exercise for anything else than that. No.
No, tell me that
you can bring out a TR murmur if you think that there is pulmonary hypertension, but for you, there isn't any clinical evidence of pulmonary hypertension. There isn't any heart failure. So probably, yeah. And early diastolic murmur, if you can bring out a little more carefully, but it's not there. So I think we are now dealt with only one murmur and one diagnosis. So
what are the causes of mid-diastolic murmur other than mitral stenosis?
Sir, that is, one is functional mitral stenosis, sir. That is AR causing Austin film murmur, and another one is increased flow through the mitral valve, sir. Like VSD, PDA, and MR, and some increased volume modulate states like anemia, thyrotoxicosis can cause this mid-diastolic murmur, sir. Apart from this, it can be heard during valvular thrombus or LA mass obstructing this.
Okay, LA mass and okay, LA thrombus or LA. Okay, good.
During acute rheumatic fever, you get a named murmur, mid-diastolic.
What is the mechanism of the mid-diastolic Carey-Combs murmur? Is it? Yeah.
Yeah.
What is the mechanism?
Valvulitis, not ships.
No, is it due to MR or is it due to something else? That's all we want to know.
MR will be usually due to acute rheumatic fever. MR will be due to valvulitis, sir. Because of this, Yes.
Valvulitis, it is probably
Yes, sir.
related to valvulitis with a little thickened and edematous valve, which may be relatively obstructive.
Yes.
It's not necessarily related to mitral regurgitation severity.
Yes.
Okay. Next
Then
slide.
respiratory system bilateral crepitations, that's or basal areas, abdomen, CNS is normal. So clinical diagnosis: acute valvular heart disease, probably rheumatic heart disease, severe mitral, no evidence of pulmonary artery hypertension. Pulmonary venous hypertension was there, NIHA class 3 with medication, atrial fibrillation with controlled ventricular rate, no evidence of acute rheumatic fever, infective endocarditis or congestive cardiac failures.
Yeah. So the just
Wait.
two questions. Sir.
Yeah, please, next previous slide. Don't go to the ACG. Let's
Yeah.
not be totally biased.
So there are two questions. Why did you say probably rheumatic activity? Are you thinking of some other etiology? And secondly, why is there so you said moderate pulmonary venous hypertension, but no pulmonary arterial hypertension. So a person with mitral stenosis who has developed atrial fibrillation and yet has not developed pulmonary hypertension. What is the cause?
No, sir.
Why is that?
P2 was not loud, sir. Here P2 was not loud, and
what do you think is the pulmonary capillary wedge pressure with the moderate PVH? What do you think is the pulmonary capillary wedge pressure in the moderate PVH?
Sir, 12 to 18, sir.
Wait.
18 to 24. 18
No,
to 24.
wait. You said there are bivasal crepitations.
Yes, sir.
So when does that occur? At what level of pulmonary?
More than 25. More than 25. Sir.
More than 25.
What is transpulmonary gradient? How much is transpulmonary gradient?
Patient has orthopnea. Patient has orthopnea. The pulmonary wedge is around 20.
Mean pulmonary artery pressure minus pulmonary capillary wedge pressure, sir. If
how
it
much
is,
is that normally?
Usually it should be less than 12, sir, in case of post capillary pulmonary hypertension.
So
if
now,
it is
even
more
if
than
you
12,
assume this is 10, what do you think will be the mean pulmonary artery pressure in this patient who has crackles in base and history of orthopnea and PVH with a normal transpulmonary
15, sir. 15, sir.
Mean pulmonary artery pressure. How can it be 15?
Sir. If I,
no, we give you the
35, sir. 35.
Let us say the PA wedge is 20, right? Will 35. This patient have pulmonary hypertension or not? Very simple question. We are not talking about pulmonary artery hypertension.
Yes, sir.
Pulmonary artery hypertension and pulmonary hypertension. What is the difference? Simple. Sir? Pulmonary artery hypertension against simple pulmonary hypertension. What is the difference?
Pulmonary hypertension may be due to venous or
no. Pulmonary artery hypertension means
that's
primary
pathology. Primary pathology, yes, sir.
Increase.
Yes, sir.
PVR is increased. That is pulmonary artery hypertension.
Yes, sir.
Any other pulmonary hypertension, the diagnosis is PA mean pressure more than 20, isn't it?
Yes, sir.
Here the PA diastolic will be 20 because the pulmonary wedge is 20 or 20. So obviously there is some pulmonary hypertension. Now there is a mixed pre as well as post capillary pulmonary hypertension it's debatable. For which of course you said there isn't any clinical evidence for that much of pulmonary.
I was not able to, yes, sir, make out.
Okay. But as sir said, when you say the patient has orthopnea, please don't say no pulmonary artery hypertension or pulmonary hypertension. Pulmonary artery hypertension, I'm not telling, but don't say no pulmonary hypertension. It's always there.
I have one question to the candidate.
Yeah.
What is the mechanism of pulmonary hypertension in mitral stenosis like this case?
Sir, there will be backward pressure, sir.
No, mechanism. Just tell us the mechanism.
What are the mechanisms of pulmonary hypertension in mitral stenosis?
Stenosis. You have understood the question, doctor?
Mechanisms. It's an atrial fibrillation and all. No? So just put everything together. We have already given you the clues. One is pulmonary venous hypertension.
Yes, pulmonary venous hypertension.
Pulmonary hypertension.
Yes.
Then comes reactive pulmonary artery hypertension, isn't it? He has been having pulmonary stenosis for 20 years.
Reactive. Yes, sir.
So there has been some precapillary component.
Yes.
Right? Two. Then third, atrial fibrillation. Some embolic phenomena can happen from the right side also. Okay. think
No,
three
what
are
is
common.
the-
Then, of course, other respiratory causes I'm not discussing, but that is enumerating on.
No, I just wanted to ask the candidate, describe the pulmonary hemodynamics in LA pressure hypertension, that is passive pulmonary hypertension. What will be the PA pressure? What will be the PVR? What will be the LA pressure? LA pressure here is 30, 25 to
Yes.
30 millimeters of
Yes, sir.
mercury.
More than 25 years, sir.
Why more than 25? Why you are so specific?
Sir, he had a crackle, so alveolar edema.
So when does that happen?
When the PCWP is more than 25.
No, what is Starling's law?
Length tension.
No, Starling's law of fluid dynamics. We are not talking about Starling's equation. Why does the fluid ooze out of the vascular system?
Increase hydrostatic pressure.
So,
So there will be decreased compliance. So increased hydrostatic pressure, interstitial edema. There will be decreased lung compliance.
No, wait. What are the major determinants of fluid movement from the vessel into the interstitial space?
One is heart rate, sir.
Heart rate?
So duration of diastole.
No. We're talking about movement of the fluid from the intravascular space to the interstitial space.
One is hydrostatic
pressure and oncotic pressures.
Decreased oncotic pressure.
And third one?
Vascular abnormalities.
Abnormalities, you have to be precise.
Precise.
Science is precision.
Yes, sir.
Vascular permeability. That determines the fluid movement. Lymphatics. So integrity of the lymphatics. If the lymphatics are obstructed, then there won't be movement of the fluid back into the vascular space. So in mitral stenosis, how many types of pH you get it? The first one is?
Type 2, sir. Left-sided.
No. From the pulmonary hemodynamic point of view, is the
pulmonary venous hypertension?
No, is the PVR normal, elevated, or decreased in passive pulmonary hypertension?
PVR will be normal, sir.
PVR will be normal. What is the normal PVR?
Less than 3 Wood units.
And the second type of pH in mitral stenosis?
PCWB will be increased, sir.
That is common to all the mitral stenosis.
Yes, sir. PVR will be low, sir.
PVR will be?
Less.
With the PVR,
The second one is associated with pulmonary artery hypertension, so PVR will be increased.
So you said less?
No, sir. I said initial first type, then second type is.
And then how do you diagnose and react to pulmonary hypertension?
Symptoms improved with oxygenation.
No. Hemodynamics. You're talking about hemodynamics. Pulmonary artery pressure, left atrial pressure, and PVR. Okay, let's move on.
Okay, let's go.
ECG, sir.
Okay, quickly. Electrocardiogram. I think Chandigarh people, Dr. You can discuss.
Chinmay.
Yes, sir.
Yeah, quickly.
There's a text deviation.
You know the diagnosis. So you, in the light of the diagnosis, tell us what is the electrocardiogram.
No. Here, very interesting. QRS axis, indeterminate. I would like to know from the candidate who has written what is indeterminate.
Thing is, equiphasic was everywhere, sir. AVL was equiphasic, and
Lead one is equiphasic?
No. Equiphasic. Not
Read one AVL. No, see, indeterminate is an escape route. Don't do that.
Yes, sir. More towards left side,
Indeterminate
sir.
is only if all of them show equiphasing. If one of them shows a positive, you should take that as the axis.
Yes, sir.
If one and
More
AVL are
towards left side,
positive.
sir. Yes, sir.
V1 positive.
Yes, sir. That's
Yes.
what I am not sure. Because
So what is the
AVR
axis?
Yeah, AVR also was.
No, AVF is more negative or more positive?
AVF is more negative, sir.
So what will
Yes.
be the axis?
So what is the axis?
If the AVF is more negative, what is the axis?
Minus 90 degrees.
So
Minus
do you
90.
get it?
Lead one is positive. Lead one is positive. AVR is probably somewhere around equiphasic or mildly positive. So it has to be between minus 60 and minus 90, close to minus 60. Okay.
Yes.
No, but in a patient with mitral stenosis,
yeah,
axis do you expect?
It should be right sided.
Yeah. So it's odd, isn't it? That's all. I mean, axis ECG is not telling you whether it's mitral or not.
Yes.
So you want to revise your diagnosis now?
No, you don't have to change your clinical diagnosis, is it not? You only give the ECG diagnosis. So there is atrial fibrillation, fairly controlled ventricular rate. It is still a little irregular. It is not regular to say there is AV junctional block.
Yes.
And then you just see if there is right ventricular hypertrophy or not, or left
Yes, sir.
ventricular
Yes,
hypertrophy.
yes, sir. It's there, sir. It's there.
So V1. Yes, sure, V1.
No, wait. Wait a minute. What is the criteria for RVH in this patient?
There was AVR. It's around.
No, wait. You have to say we are asking ECG criteria for RVH in this patient.
Yes, sir. V1, the R wave is more than 6 mm, sir.
What is the duration of QRS?
Duration of QRS is around 140 milliseconds, sir.
So, are the voltage criteria valid in the setting of a bundle branch block?
ECG, please. Yeah.
Are the voltage criteria valid in the presence of bundle branch block? Yes, no, or don't know?
Don't know, sir.
Don't know. Anybody else among the students?
I think you can be a little more critical on those questions. What about V6? When there is some intraventricular conduction delay, here it is, of course, left axis deviation and some incomplete RBUB. I don't know about the QRS duration. It may be less 110. So you look at V6. What does V6 tell you?
Yeah, deep S wave, sir. That is predominant.
And narrow. It's not the broad halo of RBBB, right? So that's another. But wait, there is still a difficulty in that. What happens in left anterior hemiblock?
Yeah.
You may get persistence of S waves in the V5. These are the things you should know, the limitations. So don't automatically say there is RVH because of deep S. It can be part of left anterior hemiblock alone, right? But in V1, if you have a little narrowish R dash, and if it is more than 7 or 6, whatever you want to call, you can arbitrarily put anyway, then you should suspect in the clinical setting that there could be RVH.
What is the normal
leave alone left axis deviation, it is left anterior block. At 67, she can have so many reasons why she could have left anterior block, isn't it? It's a conduction abnormality and not related to the valvular or the myocardial problems. Okay. Shall we go to the X-ray?
Yep.
Sir, thing is, I have prepared this case as a case of interesting case
that
of
doesn't matter, yeah. It is interesting. Let's go forward.
Thing is, pardon me, sir.
No.
I got the X-ray, but thing is, it got deleted, sir. I'm not able to recover this, sir.
Oh,
patient
no
got expired. So
you tell us your findings on the X-ray.
Yes, sir. There was no cardiomegaly, sir. There was straightening of heart borders, and there is some peribronchial cuffing. Cuffing was there, sir. Then there is no evidence of pleural effusion or other things. Then there was increased hilar the hilar
Okay.
angle is
Okay,
widened.
okay.
Then
We
there
see
was
the mitral valve. We are interested in that 67 year. Could you see the mitral valve? You know what I'm asking?
yeah. I'm not
What?
looked into.
No, no. What I wanted to know was the LA enlarged or not enlarged?
Yes, sir. It was enlarged. It was enlarged.
It is enlarged, and mitral. There's no mitral valve calcification, right? Is
Yes.
that what you want? Okay.
Yes, sir.
Good. I mean, that's what I wanted you to tell. Go ahead. Let's go to the next.
So I'm going to echo, sir.
Okay.
So here we
Good.
can see there is a concentric LV, sir. So in a patient with mitral stenosis with decreased LV filling, there is a concentric LV, and the patient BP is also normal rate, sir. There is no significant AS. So this is some abnormal finding which we have. There is also clinically there is no evidence of RV pressure overload, but here we can see there is some RV free wall thickness. So there is a thickening of AML and PML. There is AML dooming was there, and mitral wall separation index also 5 ml. So there is a mild pericardial effusion.
What is the thickness of the normal RV?
Sir, less than 5 ml.
You know, I do think you're leading us to something along with mitral stenosis. Now, we just want to know at what point in time you thought of some infiltration, you know, like amyloid or something like
yes,
that.
Sir, yes,
Just,
sir.
no,
Actually,
I'm not. Don't say yes, because we are not really still going to amyloid yet. You just tell us what all you find. You get some pericardial effusion, very unusual for mitral stenosis without right heart failure, right?
Yes.
Right heart failure, yes, effusion is there, but pure pulmonary venous hypertension, pericardial effusion is rare. Why? Pericardial effusion is a indicator of severe pulmonary venous, systemic venous hypertension, right? Pleural effusion and pericardial. But here, of course, you have some. So, okay, I'm not sure whether the RV is hypertrophic. LV is hypertrophic. Maybe you're right. Let us see. Let's just go ahead. Just run it. Okay. You are. Yes, I agree with you.
Then in short axis view, medial commissure fused, lateral commissure was free, and plani was 0.8, sir. Then in A4C, there is some
concentric LVH, isn't it?
Yes, sir. And you can see there is some
Wait. What is your definition of concentric LVH?
Sir, more than 12 mm, sir.
No, that's not correct.
More than?
More than 12 mm thickness. It's not only the thickness, it's something else apart from that. When do you say concentric LVH? When do you say concentric? When do you say eccentric? When do you say asymmetric?
PGT.
Sorry?
Relative wall thickness is...
relative. What is relative wall thickness?
More than 0.86.
Relative to what?
Posterior wall.
The posterior wall and IVS ratios.
That is not true.
That is only asymmetry.
Relative to the cavity size.
No,
cavity size and
not to the posterior wall.
Okay.
Not to the posterior wall. Posterior wall and IBS is you are looking for asymmetric. What we are talking about, you said concentric LVH. Concentric, when we say concentric, we are comparing the thickness to the cavity size. Go ahead.
Yeah. Obviously, sir is asking about concentric against eccentric. That's right, isn't it?
Yes.
What is the condition where you get eccentric LVH?
Volume overload states, sir.
Not volume
regurgitation valvular lesions.
Mitral regurgitation, ventricular
regurgitation.
No.
Regurgitation valvular lesion.
Aortic regurgitation. Not in mitral or ventricular septal defect, right?
Yes.
Only in aortic, because in only aortic regurgitation, there is some increase in the afterload. Right? Otherwise, there is no increase in the afterload. So there isn't any hypertrophy. There is only dilatation in mitral and EST. Only.
Now, I just wanted to ask, is there any thickening of the interatrial septum?
Yes, sir. It's there, sir. Then the LV, RA, RV, it's not dilated, sir. Then tricuspid valve is also not
dilated is one thing. What about the RA? RA normal or increased?
RA is not dilated, sir.
Not dilated. What is the normal?
Just run it. Just see the RV and RA. RV free wall, is it hypertrophic?
Yes, sir. It's more than 5.
Yeah, if RV free is hypertrophied, then I think there is a reason for RA to be. We'll see. We'll go forward and see. Intrahiatal septum is thickened. I agree with you. LA is dilated.
And what about the tricuspid wall?
It's not thickened, sir.
Sorry?
It's not thickened, sir.
What is the thickness of the tricuspid wall normal?
Less than 4 mm.
You mean the annular? Annular.
No. Now, how do you differentiate a hypertrophied syndromes from an infiltrative disorder?
Yes, sir. Hypertrophic syndromes, especially HCM, there will be increased asymmetric septal hypertrophy.
No, apart from hypertrophy, but what are the other parameters you take into consideration when you decide whether it is just an hypertrophied ventricle?
Sir, biatrial enlargement. Biatrial enlargement.
In HOCM, is IAS hypertrophy?
No, sir. IAS thickening will not be there, sir. Yes.
Why?
There is no muscle is
there.
Yes, sir.
That's it. So basically, if you are seeing there is interhiatal septal thickness, if you see that the leaflets are also thickened, where there is no muscle practically.
Yes, sir.
So you have to suspect infiltrative disorder.
Yes, sir.
Or,
yes.
No, that kind of a thing. So here is a patient where IAS is thickened. So
yes,
it cannot be just an hypertrophied ventricle.
Yes, sir.
Go ahead.
Then there is no regional motion abnormality and BF is also supranormal, sir.
Okay.
Then there is significant MS. Mitral gradient was mean was 14, sir. First of time area was 0.83. There is mild to moderate MR, mild TR. There is mild PSTS.
Now, where do you say moderate MR? What is your basis to say moderate MR?
No, where is? Where is MR? Oh.
There is there, but not moderate.
Okay. Yeah, it's
Sir, it's around 20 to 40.
Yeah. And there is a central regurgitation orifice. Yeah. Can call it mild to moderate. Yeah. Just modify the color of the jet and then see.
No. Interesting. You see the Doppler profile. Does this belong to the same patient? Because
yes,
sir. No, wait a minute. You go back. You see the A wave there. You see the P wave on the ECG.
Oh yeah.
Yeah. How can you say it is a?
I hope you are not.
I'm not convinced.
Yes, sir. It's the same patient only.
No, same patient. You see the P wave. You see the A wave.
Patient is in sinus rhythm, doctor.
It is sinus rhythm.
Yeah, ECG is there, right on you. No, I think there is a little issue.
No, sir. It's same patient only. During recording, it was sinus rhythm, sir.
Did you recognize that this patient has been in sinus rhythm during your recording? Anyway, it doesn't matter. Okay, but he is in sinus rhythm. But actually it's a good sign, that it's not probably a chronic AF. May have been a recent one.
A second question to you is, based on the color Doppler, not color Doppler, pulsed Doppler, do you think that the MR is severe?
No, sir, not severe. Sir.
It's not even moderate because you see the intensity of the.
Yes, sir. Color intensity was very less, sir. But thing is,
color intensity is all. It can be adjusted to anything.
Yeah, you have to adjust it to the maximum, velocity. The aliasing velocity should be 0.8 to more than 1, and then you see how much of it is the turbulent flow.
Yeah.
Peripheral bluish or that one is probably not actually MR. It's the left atrial blood being carried away by the Venturi effect. So these things we should. But anyway, you are right. There is MR, which of course we couldn't clinically pick up. That doesn't matter.
Okay, go ahead.
More important would have been if you could look at the
diastolic dysfunction.
Yeah.
Septal S prime is 7, E prime was around 3, and A prime was 4, sir. E bar E prime is around more than 15 years. Lateral is also reduced, sir.
No, septal E prime of 3 centimeters per second. Normal or abnormal?
Reduced, sir.
Reduced.
Yes.
Septal E prime.
Yes, sir.
What about the lateral?
Yes, sir. It's also reduced, sir.
How much is it?
6, sir.
Lateral,
2.
E prime is only 2 centimeters.
Yes.
So what does that suggest?
It suggests intrinsic muscle abnormality, sir.
No, E stands for what?
Yeah, early diastolic filling, sir.
So it is a diastolic dysfunction.
Diastolic dysfunction. Yes.
Severe diastolic. What is the normal E wave amplitude?
Yes, sir. In septal
Prime
E prime,
amplitude.
yes, sir. Septal it's more than 7, sir. Lateral it's more than 10, sir.
So basically, it is a severe diastolic function.
Yeah, I think with septal E dash, basically that means there is a ventricular dysfunction, isn't it?
Oh,
I think maybe you can do your strain imaging, longitudinal strain imaging, and that
Yes,
will give
sir.
you
Yes,
better
sir.
clue.
Yes,
Okay.
sir. Then RV dysfunction is normal, sir. There is no RV.
Okay.
Then I have done strains, a strain rate analysis. It's global GLS around 8.3, sir. And apical region, it's
No,
reduced.
it is not. There's no.
Not a typical. It's not typical, is it? That
Yes,
apex is
not, yes,
no,
tried,
normal
sir.
and the
Yes.
base and the mid segments are abnormal.
Yes. I have tried twice or thrice, but this is the finding I got.
So it's not typical of.
Yes, sir. It's not typical. Yes, sir.
Okay.
And
so what next? So what is the next step?
Yes, sir. So
Next
what's
step to make a diagnosis.
Yes, sir. We have done markers. NT-proBNP was elevated. Drop was positive. Renal function.
Wait. If you're suspecting amyloidosis,
Yes,
what's the next imaging?
There are two things, sir. One is first we have to rule out AL amyloidosis, sir.
Okay, good.
Immunofixation and other things.
So what does it show you? Your blood test or whatever?
Yes, sir. If it's negative, then we have to go for ATTR. Yes, ATTR. Yes, sir. ATTR amyloidosis, sir.
Okay.
For ATTR amyloidosis, we have to do technetium pyrophosphate scanning, sir.
Was it done?
Yes, sir. It was done, sir. It was done, and yes, sir. There was grade 2, sir. Cardiac with mediastinal ratio was more than 1.3, sir. So there was.
Was it a SPECT or was it just pooled?
SPECT, sir. We done with SPECT.
So it is SPECT. Yeah. So
we
what
done
is
with
it?
SPECT.
Actually, you're supposed to compare the myocardial uptake versus the bone uptake.
Yes, sir. Perguni
Bone
score was
uptake
also
on the ribs.
Yes, sir. Perguni score also they have done and we have analyzed, sir. It is also grade 2, sir. So it's a ATTR amyloidosis. We have not done genetic analysis, sir. We have not done. We have planned for that, and we also planned for some the financial issues are there, sir, regarding the ATTR therapy. So we plan for that, but patient
do you get an elevated NT-proBNP in patients where the LV and diastolic dimension is normal or less than normal?
Yes, sir, we can get, sir.
Which one? So in the heart failure with preserved ejection fraction, NT-proBNP is normal or elevated?
No, sir, elevated.
Which one?
NT-proBNP.
NT-proBNP in heart failure with preserved ejection fraction, 30% of them will have normal NT-proBNP.
You see, the elevation is certainly not as much as in reduced ejection fraction. And a few of them, I mean, it may not be diagnosed. It may be diagnostic if it's elevated, but it doesn't rule out if it is normal.
Actually, he said that in a patient with concentric LVH, NT-proBNP this much elevated 2000 picograms, it is a cardiotoxicity of the amyloid material that causes it. It is not the stretch.
Yes.
It is not the stretch. It is actually it does have an impact on the atrium that really results in paroxysmal AF. And this probably patient, as per the data shown to you, we had one ECG wherein it was atrial fibrillation. We had one ECG along with the Doppler where it showed a sinus rhythm. So this concentric LVH with markedly elevated NT-proBNP one of the red flags is supposed to be a amyloidosis.
Yes, sir.
Yeah.
What is the serum free light chain assay?
Yes, sir. Thing is, we don't have that light chain assay in our institute. We don't have that, sir.
Yeah,
we
so
need to
then you cannot diagnose ATTR
Yeah, yeah.
amyloidosis.
Yeah, yes, sir. I know, sir.
Serum
Yeah,
free
yes,
light
sir.
chain assay normal
Yes, sir.
only
Yes.
then pyrophosphate.
Yes,
So
yes, sir. Yes, sir.
pyrophosphate scan may be normal even in a
Yes, sir.
AL amyloidosis.
Yes, sir. Yes, sir. Yes, yes, sir. But
actually you're supposed to check kappa and lambda.
yes, sir. Free light chain ratio.
Free light chain ratio.
Yes,
That's
sir.
supposed to be more reliable.
Yes, sir. Immunofixation. We have done only serum protein electrophoresis, sir, and it turned out to be negative. And there was no.
That's very crude, actually. You're not supposed to do that for that matter.
Yes, sir. Yes, sir. Yes, sir. Yes.
So you're talking about not the wild type, but the other one. So because wild type is usually only heart is involved, but here the kidney is also probably involved, isn't it? Kidneys,
Yes,
you got significant elevation of the creatinine and. Okay, now you can. This I am not familiar with. You can just discuss. Anybody who is familiar with this.
But I think even if not available, you must do the serum free light chain assay because if AL amyloidosis is missed, the person will worsen.
Yeah, yeah, yes, sir.
No, it is a onco disease. Yeah. Onco disease, there is a treatment for it.
Yeah, it's very much treatable and.
So you'll be missing a.
We have done fat biopsy and turned out to be negative. And for renal, she had increased renal parameters. Sir. Creatinine was around 3. That was non-oligoic. So we don't know what is the cause for this native kidney disease, sir. When we discussed with nephrology, they said it can be due to cardiorenal syndrome or it can be due to a amyloid pathology. So we planned for renal biopsy also, sir. But in the planning process, patient heart failure worsened, sir. So she went into cardiac arrest and patient got expired. Sir. So we are not able to complete though. We are on the process of workup, but
you get a partial autopsy or something?
No, sir.
Partial autopsy?
No, sir, not done.
No, a full autopsy. Today nobody agrees unless it's a medical legal. But partial autopsy you can.
Workup was incomplete, sir. We are on the process of all the things like arranging for ATTR, like on the same time, same patient regarding. We discussed with hematology also. Like we have done serum protein regarding assay like fixation and other things where we can get it in low price and other things. But during this process, patient worsened and got expensive.
So if it is amyloid, what would be your option? What would be the treatment option? Is there any treatment for amyloidosis currently?
Yeah, yes, sir. Right now is there, sir. So there are AL amyloidosis and ATTR amyloidosis.
Yeah, anyway, we are rolled out now. We are talking about the other one.
Sir, ATTR amyloid won't involve the kidneys, so I think kidney biopsy would not be a good option.
Yes, yeah, we plan for that, sir. Thing is, we don't know whether the renal involvement is because of amyloid or it is because of some CRS or it is because of some other cause. They are also not sure, sir. The nephrology department we discussed, and they are also not sure whether this is due to amyloid question. So regarding ATTR management, there are two things, sir. One is TTR silencers and TTR stabilizing agents. So TTR silencer, there are two things. One is siRNA and antisense oligonucleotide. siRNA is patisiran, antisense ASO is inotersen. So both are approved for only neuropathy. So for cardiomyopathy, we have to go for only TTR stabilizer. So like
Tafamidis.
yes, sir, tafamidis and diflunis, sir.
Tafamidis is very, very costly.
Yes, sir. We have asked for the price also.
No. I have got one patient on it.
Yes, sir. We
plan to the patient 70,000 rupees.
Yes, sir. It's around 60 to 70,000.
Yeah, per month.
Yes. So
and then the patient's son said, "My salary itself is only 50. How can you expect me to buy 60,000 rupees worth of the?" Finally, he got it approved through the government. Actually, it is a central government-based organization, NFC. They got it through, and then it was given. The drug was given through the agency. He didn't buy it.
So these investigations done through schemes. So that's why we are able to do this pyrophosphate and other things. So that serum we are not able to. They are not.
At least somebody in the chat box has written melphalan. Melphalan is specific for AL amyloidosis.
AL amyloidosis.
Yes.
AL only. I think of course we should by all means rule it out because that's better treatable
disease.
The other type of.
Okay.
I must congratulate your institute for having suspected and then whatever is available in a government hospital for evaluation of amyloids. I think that's a very good point. I do agree retrospectively everything looks quite nice that hypertrophy, interatrial septum is like thickened and all that. But when mitral stenosis is the overwhelming diagnosis, we have thought of this because ECG also doesn't show very low voltage pattern and all. Otherwise, low voltage pattern in the QRS usually tells you that there is some myocardial disease than in addition to whatever rheumatic. Rheumatic, usually the voltages don't get increased. QRS voltages.
Actually, when I reviewed the literature about this discrepancy between the echo and ECG criteria, that low voltage is seen in only 25% of the patients.
Yeah, that's true.
With proven proven amyloidosis. So it's not that common. So the
that's correct.
That should not.
Most of the time, the ECG will be a low voltage in the end stage disease. While today, with modern techniques of diagnosis like care, you keep diagnosing amyloidosis much earlier, where you don't really have to get into that myocardial dysfunction because of large amount of amyloid in that.
Now, knowing all the disease now, we just want to go back to the history. What was the disease that was causing the problem first? And then was it late onset of...
we discussed it, touched upon it, but then he dissuaded us from further discussion. He said, no, the patient was continuing to be symptomatic. Otherwise, you would have thought of another pathology.
Like this. Patient has a rheumatic heart disease for which she got relief with probably decongestive therapy. And again, she had this new disease, amyloidosis.
The second worsening or second recurrence of symptoms was probably due to an acquired acquired. Now, retrospectively, that history was probably a little indicative that there are two pathologies. Doesn't matter. It's always learning. Don't worry.
It's always learning. These patients point us the
it's a good case.
lacunae in spite of high imaging technologies. Probably in the good old days, we would have sent it as only as mitral stenosis and death.
Justin, would you like to just summarize your overall concept and Justin there? No. Okay, then let's.
Sir, I have one question, sir. Was she ever put on digoxin before she was diagnosed with amyloid or not? Because she had worsening of symptoms. Digoxin could worsen amyloid, maybe.
No. Actually, if you see the ECG where the atrial fibrillation was there, the ST segment depression looked like a defect. You go back to the ECG.
Yes.
Showed that.
Whether that left axis deviation.
Amyloid could cause digitalis toxicity also, sir.
No, that is a bit more frequent.
I have no idea, but
trapped in
maybe
the myocardium.
Maybe. Yes. If this is myocardium, the digitalis toxicity is likely to be more common. I agree with you. Unlike rheumatic valvular heart disease, where the myocardial factor is very little. It is mostly mechanical. And only very late there is.
This is the one.
That
V4, it looks like a, it is.
Whether the conduction system in my left anterior hemi-block would have given us a clue that it is a myocardial disease. Sarcoidosis, yes. Sarcoidosis involves a conduction system because it involves the septum, higher septum. So you can get AV blocks, complete heart block out. Amyloid, I'm not so sure. Maybe. But you can just go and check up whether amyloid also causes some conduction abnormalities. Like here only there is a left anterior hemi block and some incomplete RV. It's certainly not a full RV. Yes, good points.
I have a question. Could something have been done for the mitral valve? Yes, to the Dr. Tharan and Dr.
Can we hand it over to Venu and Hari?
Just because we had the primary hemodynamic problem was mitral stenosis. So could something have been done for the mitral valve lesion? I was just wondering. Obviously, with a diagnosis of underlying amyloidosis, we would not hesitate. But I just wanted an opinion. Hari is not there.
I think there is no harm in opening up the mitral valve. So it could be whether it will reduce the congestion.
Yeah, obviously.
But looking at the valve, sir, the Wilkins does not look suitable for BMV. Seems severely calcified.
I cross-sectionally also I realized that there is some calcification at the lateral commissure area, and the commissure fusion is not as much as we would have expected.
Okay.
And certainly there is central MR is of course acceptable in mitral stenosis, because they say that with the mobility of the valve after opening the valve, the MR often disappears.
Yeah, it improves.
Eccentric MR, then obviously, and if you say it's moderate, then probably we would be a little more careful. And with the myocardial disease, certainly she wouldn't tolerate any more of LV volume overload.
Yeah. And the thickened atrial septum would also be a relative problem for balloon mitral valvuloplasty.
So she collapsed and all. In that situation, probably, I don't know whether opening the valve would have made a difference.
Extremely interesting case.
And nowadays, we are getting these types of valves with the calcium, at least one conventional calcium. I think we are not getting the older type of good patients are above 40, 50, 60. No young patients. No, very rarely we get a young patient with mitral stenosis.
Yeah. That's correct. In the West, they would say that an elderly at 70, heart failure, rheumatic is going to be the least common. We'll think of all other things rather than rheumatic. But of course, here mitral stenosis is there. Mitral stenosis, I don't think you have to look around for etiology for the valve. Then myocardial disease, you have to look around for, I think just well investigated, the limited availability of, various diagnostic tools. Okay.
Thank you. Very, very interesting case. Excellent discussion also. A lot of learning points. I really enjoyed this.
Yes. Two things we have suspected. Two things that made us suspected this. One is in MS patient, why there should be a LVH with no AS and no increase in BP. And another one is that IA is thickening. These two things we thought in terms of methods.
We had recently a case where we did a biopsy. Electrophoresis are all were negative. We did a biopsy. It showed cardiac endomyocardial biopsy that showed this one. So that was the patient was sent to RCC, and it's a staff nurse, 27-year-old. No other findings from cardiac biopsy. We could suspect, and she is now better after chemotherapy.
We had a wonderful session. I must thank both teams from Madras Medical College and from PGH Chandigarh for giving us this opportunity. I thank all the examiners, Dr. Jagan Mohan Tharan sir, Dr. Dayasagar Rao, Dr. Justin Paul, and Dr. Ajay Behel for the excellent discussion. Congratulate Dr. Sudarshan for giving a well worked up case, and the discussion was very useful. Well done to the student panel, Dr. Chinmay and Dr. Sudeep for the discussion. We must also thank Dr. Ariswan for the excellent and very concise talk he gave regarding interpretation materials using Boris plot. So that is also great. We continue to go into the 4th year of heart failure masterclass, and I should thank Chopra sir, Harishan sir, Venugopal sir, Dr. Abraham Moment, Dr. Sajan, the entire team behind the heart failure masterclass. We've been collaborating with Heart Failure Society of America as well, Coronas Pharma, the entire audiovisual team, Hallmark, and everybody for the session we've been having, monthly sessions we've been having for past several years now. So we'll get back next month, on second Saturday, for the next edition of the Heart Failure Masterclass. Back to Haryushan sir for the concluding remarks.
The next program will be on May 10th. MMC will continue with the panelist, and we will have one more. The other case presenter will be from some other institute, and the presentation will be from Heart Failure Society of America. The topic and all we will announce. So it will be on May 10th, second Saturday.
Thank you all, and
Okay.
Great.
Thank you everyone for joining, and good night.
Thank you. Good night.
Right.